I'm impressed. This is serious stuff.
Thank you. We've come a long way. So
am I going to be famous now?
Yes, even more famous.
It's your big break.
Oh God, I'm nervous now.
Welcome to the show, Dr. John Kelly.
Thank you.
We're going to be sure to pin your accomplishments and what you do for work in the episode bio and all of that. But it's good to have you. And I will be remiss if I don't mention that this is our second podcast together.
That's right. That's right. It was long ago, over 100 years ago.
Yeah,
first one.
In Boston and in another life, we came and hung out with you at the RRI and met Brandon Bergman.
That's right.
And had some good conversations about the state of recovery research and 12-step addiction treatment research. And so I'm grateful. I'm grateful that you allowed us to do that. We did get to go to a Boston Red Sox game.
Yeah.
And I'll tell a funny story because Boston does have, subways. What do y'all call them, though?
The T.
And we were on the red line.
Mm-hmm.
Obviously, it has to be the red line if it's going to take you to Fenway. But we're going to this, me and a friend of mine, his name's Austin Monserrat. He was the other host.
Oh, yeah.
Yeah, and
right.
He lives in Maine now, actually. But we went to a game, and I had never been to Fenway. And so we're, as you get closer, you get more passengers headed that way in red.
Yep.
But what was interesting, I felt like I was on the set of Ghostbusters because at some point you get on the red, and we got on a old subway car. Like you could tell the difference in the ones that have been around for a while. And it was so packed that the person driving the subway and the workers had to get out and manually push the doors because the weight had, pushed the car down that the doors were stuck on the platform.
Okay.
Because there were so many people.
Incredible. Kind of scary at the same time.
Yeah, a little bit, but no one seemed afraid, so we just kind of went with this is like a par for the course. So, but thank you for spending time today. I wonder, in your own words, if you describe, I know you've done what you did for us today in terms of a presentation to our staff many, many times over many years. How would you describe what that was, what you did for us today in terms of that presentation?
Well, I guess I would describe it as an overview of the highest quality research pertaining to 12-step treatment and mutual help group involvement like AA, as well as, kind of looking at the efficacy and effectiveness of 12-step treatment, as well as the mechanisms through which those treatments confer benefit to prevent relapse and promote recovery.
And does it always feel, I'm leading the witness a little bit, but one of the comments you said that is most common after those presentations is the gratitude. Gratitude from staff that work in a facility like Cumberland Heights. And can you share what that sentiment usually is? Yeah,
usually it's thank God this guy stopped speaking. That's what they're most grateful for.
I'm sure.
Finally, he stopped.
Yeah, right.
Now, other than that, what they say is they're grateful because the research really validates their personal lived experience. So it kind of really underscores that what they've themselves have observed and lived in their own recovery, because many of the staff, as you know, are in recovery themselves, but also recovery support service workers around the country where I've spoke. They say the same thing, thank you for validating my lived experience, my personal, because it's very empowering and validating to get that verified scientifically. Not that they needed it, but it kind of is empowering, I think, to see that the data points all add up and converge consistently on this same kind of benefit that's attributable to engagement in these groups.
Why do you think that there's a lack of recognition over the validity of these types of programs in our country?
Well, I think really, there's a couple of things. I think one is the spirituality, religious kind of overtones and undertones around 12-step, which I think is viewed with skepticism from a medical scientific standpoint, is that people somehow view that as it's not conducive to scientific inquiry and evaluation in the same way as other kinds of treatments are. And so there's always a kind of a question mark over that. And then also historically, there's been a lack of rigorous, systematic application of scientific principles to that database. And that database really has only come about in the last 35 years since the Institute of Medicine back in 1990 called for more research specifically on 12-step treatment and specifically on AA, on Alcoholics Anonymous, because at that time there was very little rigorous research, despite the fact that the majority of treatment programs were advocating for 12-step involvement and basing their treatments on 12-step principles and practices. And, really up until the first systematic review of AA and 12-step treatment was done in 2006. We just did another one in 2020, which back in 2006, I think there were 88 articles, 8 papers published. And now in 2020, when we published the latest one, there were 27 trials. So you can see that magnitude growth. And so there's been, a concerted effort to try and subject the available data, which is now very high quantity, courtesy of the call from the Institute of Medicine and the funding from the National Institutes of Health and Department of Veterans Affairs, where we've been able to actually say, look, there's a ton of studies now. There's dozens and dozens of these trials looking at this. We need to systematically evaluate it and look to see, is there a real benefit? And now we know there is. So now that was only in 2020 that we've really, been able to clarify that with a degree of confidence that is on par with other kinds of confidence in other kinds of medical treatments. So I think that's going to change things going forwards.
Yeah. I think it's also important to point out for anybody that's listening to understand the difference between, evidence-based medicine and evidence-based behavioral health. In that when you go to your training programs, whether you're an LPC or a social worker or a marriage family therapist or what have you, that you're introduced to a series or set of models, interventions, and theories associated with that domain. And you're taught how to reflexively adapt those to the person and the problem in front of you. And what's interesting about the research that you presented today is how we're starting to compare some of those modalities, some of those manualized treatments, with what we consider to be 12-step care, 12-step addiction treatments. And I wondered if you could speak to that a little bit, TSF versus CBT versus ME, and some of those group mean differences that have been found and are fact in terms of how they manifest and change in individuals who are addicted.
Yeah. Well, what you're alluding to, Nick, is just the different kinds of comparison treatments. Now, in the last 50 years, since the birth of the National Institute of Drug Abuse in 1974 and the National Institute of Alcohol Abuse and Alcoholism in 1970, there has been tons of new treatments developed in the last 50 years based on sound scientific principles of operant classical conditioning, neuroscience, et cetera, to be able to develop pharmacotherapies as well as psychosocial interventions, including the ones you mentioned, which are cognitive behavioral therapy and motivational enhancement therapy. And those are considered kind of state-of-the-art interventions for addiction. They are kind of the meat and potatoes or the tofu and quinoa, depending on what you prefer, of the treatment world.
Or the meat and three.
Or the meat and three.
Yeah.
Even better. Of the treatment world. Nick just taught me the meat and three. I didn't know what that was. So I'm getting acculturated.
Yes, right.
Thank you, Nick, for that.
Yeah.
I'm going to brag about that when I go home.
Yeah.
Drop it in every now and
then. Yeah,
again.
sure. And people are going to say, wow, he knows his stuff. Yeah.
So what are we talking about?
ME, CBT, TSF.
Yeah. Thank you. So those are kind of, again, they're based on sound scientific theories, as you mentioned, and principles, and then practices are developed to try and address those deficits that are associated with relapse and being able to, lack of ability to maintain behavioral changes over time. And those are standard practices. There are others, of course, things like contingency management. There's family therapies, there's couples therapy, developed specifically for addiction, which are also helpful and effective. And then 12-step facilitation was developed in the 1990s, what they call 12-step facilitation, which was essentially 12-step treatment. It was designed to, which 12-step treatment is, of course, is designed to, stabilize people and then get them involved and engaged in this community of peers with lived experience who have found a way out of addiction and into sustained remission through practice of the 12-step principles of AA. And so treatments were formally developed in the 1990s, and then they began to be tested, these 12-step treatments, because people wanted to understand, including the Institute of Medicine, as I mentioned, when they put out a volume in 1990 called Broadening the Base of Treatment for Alcohol Problems, they wanted to get more rigorous data from the scientific community and really subject 12-step treatment to the same kinds of standards that any other treatment would be subjected to. Yeah. And that's what's happened in the last 35 years. And what I talked about today in summary was kind of the aggregate, kind of data across really accumulation of all the studies that have been done. There has been hundreds and hundreds of studies done now on 12-step treatment and AA. Most of those are non-randomized studies, but right. There's a large subset of several dozen studies which are randomized studies, which I summarized, and we published in a thing called the Cochrane Collaboration Report in 2020. Now that is kind of the gold standard in academic medicine. It's the standard. It's the place where governments or large treatment agencies in nations look to decide what to adopt and implement in their healthcare systems. So we wanted to do a review and subject 12-step and AA to the same standard. That's what we did. And what we found actually was a surprise to us, and I think a surprise to many people, was that 12-step treatments, this fairly unsophisticated linkage of patients, education and linkage and monitoring of patient involvement in groups like AA for serious alcohol problems, for example, did as well as these other treatments that you mentioned, cognitive behavioral therapy or motivational enhancement therapy, but they did much better in terms of helping patients sustain remission across time, across up to 3 years. So 20 to 60% higher rates of sustained remission across 3 years relative to what most people would conceive to be the standard of care, which is things like cognitive behavioral therapy. So not only that did they do as well or better when it comes to sustaining remission, but they also were shown to dramatically reduce healthcare costs. So because, in part, patients who are in sustained remission, which patients who were assigned to the 12-step conditions were, they were not ending up in the emergency room or overnight stays in the hospital, which tend to be expensive. So they're reducing healthcare costs there, but also they utilized less mental health services because they were sober, they're in remission, so there's less degradation and influence in the neuronally in the from a neuropsychiatric perspective. So there's greater stability occurring there over time. As well as a lot of people are using mental health counseling to address things which can be addressed through peers in AA. And that's what those studies found, is that they were able to address a lot of that kind of general angst, recovery-specific angst or other angst, anxiety, depression, through their peers. So that alleviated a lot of the same. So they didn't need to utilize formal treatment services. That saved money that way too. Yeah,
what's interesting about the Cochrane Review, just to highlight that a little bit more, is it is the highest standard to which any literature can go through to make sure that it is valid.
Yeah.
And instead of kind of unpacking, well, wait a minute, what do they mean when they say God, or what do they mean when they're talking about higher power? It was really the recognition that the mechanisms, whatever's happening, which we'll talk about in a little bit, because further studies have been completed that are trying to isolate what is it? What is being gained that's helping somebody regain what's been lost or stay abstinent. It's important that scaffolding, if you will, the framework to the house, I think I've heard you reference it in presentations past, that's what those treatments really provide, above what is available in an ME platform or scaffolding or a CBT. And I think that's why people really resonate with it. Because it's that natural lived experience of somebody saying, that's exactly right. That's how I felt. That's what I got out of a recovery experience. I was around other people that it maybe wasn't a burning bush, but the process over time is what really helped me or this group that I was a part of change, and that plugging into that healthy community and the structure that provided really unlocked an ability to experience recovery, however I define that. And ultimately, you led everybody down to this phrase that you repeated a few times, which is, public health's free lunch. And that's what you equate these programs to. I wondered if you could speak to the free lunch a little bit.
Yeah. Well, the idea there, of course, is that, given, the benefits that I just mentioned, and you're quite right, is that the Cochrane Library, the Cochrane Review that we published and conducted through the Cochrane Library is considered the gold standard.
Yeah.
It is the top level of scientific rigor and evidence, but this was applied to 12-step. And it showed a benefit when even under the most rigorous circumstances. And like I said, when you consider that these treatments that link patients to AA, to the 12-step community where they live and work, not only does it produce better outcomes in a very deadly disorder, and we're talking 180,000 deaths attributable to alcohol each year in the United States, 3.3 million around the world, a highly deadly disorder. It helps them not only stay in remission, but actually reduces healthcare costs, and it's free in the community in which people live. That, from a public health standpoint, that's why I call AA the closest thing that we have in public health to a free lunch, because it's a freebie. It's just a natural thing that has occurred and grown. Henry Kissinger described AA as America's gift to the world, for example, because it is a free, indigenous, ubiquitous resource that alleviates so much suffering and death and disability. That is a free resource that is can be linked to from treatment settings. So that is why I describe it as the closest thing that in public health that we have to a free lunch.
And importantly, I want to call this out too, because the samples from those studies are referencing the most severe cases, as you mentioned, right? Yep. So because we know there are other data, we didn't talk about it much today, but I think you've actually written on this in years past, but that most Americans who experience, a diagnosable level of substance use disorder resolve those issues in isolation. In other words, without professional assistance. I mean, there's data to support that. But for those that need professional services, and I think you said it very eloquently, i.e. safe medical detoxification and safe structure and a residential or outpatient level of care to be introduced to these themes. Those that a lot of the studies in the Cochrane Review are really talking about those treatment need population. Isn't that true?
It is. That's right. Exactly.
Yeah.
So all of those studies that we summarized, they were all treatment studies. So it was in fact a test of 12-step treatment.
Yeah.
So these are, you're quite right, Nick, these are the more severe cases, typically needing detoxification, metabolic stabilization in those first days and weeks that enables them then to be able to think straight and operate, without that burden of the craving of acute withdrawal.
One of the criticisms, rightfully so, I think we should always ask ourselves questions and be critical internally and externally as to how we do things and why we do them and how they help people is, well, wait a minute, Alcoholics Anonymous or 12-step culture, that's something free, but you're charging me for it. And I just want to call out the discrepancy between, professional services and stabilization and introducing you to the resources we have accessible, i.e. the free lunch, because we know that the longer that you're engaged, that was something that a lot of, I think, our staff took away, manifested by a question by one of our team members, which was, well, is there a greater treatment effect? Have we observed a greater treatment effect if we stack evidence-based interventions on top of each other in an acute time period? And I thought your answer was really interesting and speaks to, I think, what a lot of the data support in terms of engagement. Can you talk about that a little bit? Because I think sometimes, like you said in the presentation, when I come to treatment, I want you to fix me. I want you, like a broken femur in my leg, fix my broken bone so then I can return to the lifestyle to which I was living before, right? But behavioral health is a change over time, not overnight. And I thought that interaction we had with our staff and you was really powerful.
Yeah. No, I think, the way I think about recovery fitness or the ability to stay in remission is like physical fitness, is that you need, in order to stay physically fit, you can't go to the gym for 30 days and then never go again and expect to stay physically in good shape. You have to build in physical fitness into your lifestyle to stay physically fit. The same is true of recovery fitness, if you will. So in order to stay in fitness for recovery, to stay in remission, it's kind of wash, rinse, repeat. You need to find a lifestyle that's conducive and supportive to long-term change and long-term stability. This is what people do who are successful in recovery. So the intensity versus extensity. Intensive treatments are important. They're life-saving, like you mentioned. Detoxification, stabilization, acute care services. Those can be life-changing and life-altering. But that's the intensive. That's your 30 days in the gym, 24/7, as it were. You got access. But then what do you do once you're out of that phase of care? You need to find a way to continue to do some kind of physical fitness, if we stick with that metaphor, that's going to help you to stay physically resilient. Yeah. To be able to adapt to the demands of life. The same is true. The demands of recovery are real. There's a lot of emotion dysregulation. There's neurophysiological reparation and recalibration that goes on in the early months and years of recovery. And the central nervous system takes a long time to recalibrate and readjust. Why? Because there's been chronic poisoning over sometimes decades, where the brain has tried to adapt to these abnormally high levels of these substances that produce these adaptations or maladaptations, as well as necrosis, death, cellular death in the central nervous system. So there's a lot to be changed, and people are very vulnerable early on, particularly in the first few years. And as I mentioned today, to be no more likely than anybody else in the general population of meeting criteria for one of these disorders in the following year. It takes about 5 years of continuous remission for people who've had the disorder. So that means, we're not talking about 5 weeks or 5 months, but 5 years of elevated risk relative to the general population before you're at the equivalent risk in the general population of meeting criteria for one of these disorders in the following year. So we're talking about a long-term rehab, if you will, quote-unquote rehab, where people need an environment that's conducive and supportive to long-term healing. Another metaphor I use, but I didn't use today in my talk, but I think it's another useful one, at least for me, is this notion of, like a sick plant. When you have a diseased plant, there's only so much you can do to that plant organism to cure it at that time. Rather, you can give it a little bit of moisture and TLC at that particular time. But what do you have to do? You have to create the right soil, the right temperature, the right moisture. When you create the right conditions, that plant organism will not only survive, it'll actually thrive and flourish.
Right.
When it's in the right environment, under the right conditions. The human organism that's been poisoned chronically, from the drug, again, we can detoxify. There's only so much we can do at any given time to that human organism, but rather we have to create the right conditions for Mother Nature to do her job. And when you take the poison away, you create the right conditions. I call that psychosynthesis as opposed to photosynthesis. Mm-hmm. So it's kind of like a psychosynthesis that occurs where these right conditions, the social environment, the activity levels of physical activity and jobs and education, as well as nutrition and emotion regulation, those different elements.
Yeah, and it's going to lead us into the ingredients and what the ingredients of recovery are for different groups as a function of their age or their recovery status. One of the things that I think is really important for us to recognize is that when you come to treatment, you might not be ready to be introduced to the hardest themes psychologically to tackle throughout your life. I think about it in terms of what we know in trauma care. So I'm a person in recovery. I know that you know that about me. I have a community of recovery that surrounds me. You know, I've been practicing recovery for 15 years, and what I have learned about my own experience and also the experience of those around me is that the work psychologically, spiritually, physically wasn't completed within the 30 days of treatment that I went to 15 years ago. In fact, likely that work was pure stabilization. Mm-hmm. I mean, I got to tell you, I was just, you know, and most people are, you know, when they go to treatment, are trying to do everything they can to just wake up in the morning, put their pants on the right way, and make it to group on time. Mm-hmm. Whereas 10 years down the road, we might be reconciling with some serious trauma work or physical health work at that point. That's only appropriate at that point, only accessible at that point. So you can't, it is very unlikely that we're going to pack in all the change that needs to happen in treatment over 22 days, over 28 days, and then say, we're so glad that you were here. Good luck with you. Go to your 3 meetings a week for the rest of your life or what have you. Build a successful structure in recovery. So I think that is something, again, just to harp on, that the power of recovery and the recovery frameworks is being introduced and making sure that you make it to the next engagement state, if you will, post-treatment intervention. One of the unique data points, and I want you to know I didn't speak up because I knew the answer of, you know, the ratio or the percentage of individuals that make it to treatment if they have a friend waiting there for them or not. Can you speak to that? Because that's really, there's always a gasp in the audience.
When you see those linkage, the warm handoff. Right? Yeah. Well, that's really interesting. Just, you know, what you're referring to is the studies that have been done, which have what they call the warm handoff, which is linking patients to AA, and how important and significant having that peer-to-peer connection. Incredibly valuable. And there was a study done in 1981 that I mentioned today where people who'd never been to 12-step meetings before were randomized to receive a standard referral, which was basically a meeting list and encouragement to attend, versus the same thing, a meeting list and encouragement to attend, but also a conversation with a peer who was already engaged in 12-step meetings and arranged to meet them at a meeting. And so they compared those two different, it was an experiment, so they randomized patients to receive one or the other. And then I asked the audience, you know, what proportion of the patients got to their first meeting in the standard referral, what percentage of the patients got to their first meeting in the enhanced referral where they spoke to a peer. And the answer, of course, is shocking because it's 0. Nobody went in the standard referral. Again, these were people who'd never been before, so they were completely naive to it. But just giving them encouragement and a meeting list was completely useless, whereas in the other group, everybody went. Everybody. So 100% went to their first meeting, and in fact, 2 to 3 meetings in the first month on average.
Can you speak to how rare that is statistically from a research perspective to have your protocol 0 and 100? It doesn't happen.
No, it's that's the only study I've ever seen.
Right.
But it's just a stark example of the power of the connection with a peer. Now, you do have to take that extra step, but it just shows the payoff. If you're serious about really affecting change, then taking that extra step and getting a peer to connect with your patients who's already embedded in the community of lived experience and recovery, that can make all the difference to somebody actually making it over that threshold into their first meeting and getting engaged by that community. And we do know that people who are engaged in those meetings have 3 to 5-fold better outcomes.
Yes, and what were those ingredients? Because there were 3 of them that you talked about that were interesting. That you could probably guess if you're listening, what would those things be? You know, if you quote unquote prescribe that, hey, I think it's a good idea, Lauren, that you start going to meetings. You know, I'm your family. We want you to be around. We want you to be safe. You know, and I like the way that you talked about. There's a difference between going to a meeting and going to a meeting. And what were those 3 things that you highlighted?
Yeah, so the kind of 2 of them are ones that people may have heard before, which is getting a sponsor, using a sponsor. who is like a 12-step mentor, somebody who's got that more longer duration of recovery and lived experience that can help you early on in particular. So having a sponsor, using a sponsor, going to 3 or more meetings a week was another big factor. Obviously, you have to go to the meetings. It's
Right.
fundamental. But 3 or more meetings a week, again, was another additive factor. But an interesting one that came out was sharing at meetings. So actually verbalizing, saying something during the meeting that had another additive effect, independent of those other two. So going to 3 or more meetings, having and using a sponsor, and then also verbally participating in the meetings was also an additive, independent factor.
And what was the outcome?
So this was relapse risk. So
Yep.
you're looking at relapse.
So those 3 things, I mean, that's so fundamental, but if you, and it's more about not what we think about what those things are actually doing, but the unspoken impact that might otherwise have on your mental state, your emotional state. So think about walking into a meeting that you don't know anybody. How likely are you to then go and say, John, I really liked what you said. Will you be my sponsor?
Right.
How likely are you without that guide to speak up? We don't know the cues, we don't know the language or even the people. And so it makes a lot of sense that when we look at those data in terms of relapse risk over time, that participation, consistently attending 3 days a week, which is a commitment. I mean, you got to drive there, you have to show up, you have to make a decision that's important to you. I mean, that's something that sometimes we minimize, but that's a big deal. If you have a family or if you have a job, what time are you going to go and all of that? Not only that, do you have somebody that I like how it's have a sponsor / was it using a sponsor?
Right.
Because there's probably a difference there that I can identify with, having a sponsor in name or not, and then sharing. Because I don't know about anybody else that might be listening, but I've been to an awful lot of, certainly you don't need to share in every meeting you go to. That's not what I'm trying to say. But there is power. There is emotional power in being able to go and I think it's beyond our understanding of what's really happening, of really forcing yourself to say, hey, my name's Nick, I'm an alcoholic. And commenting on the topic for today. That's a much bigger jump than just showing up and having your meeting sheet signed. And it makes sense. There's power to that.
Absolutely. It's talk therapy, right? And that's one way of thinking about it. It's, if there's no talk, there's no therapy. As I think, I did some of my clinical training in San Diego, at the VA in San Diego, when I was a PhD student there. And one of my supervisors, we used to run groups together, and he would always say to the veterans, in our group, these were dual diagnosed patients with addiction and other mental illnesses. He'd say, come on, guys, this is talk therapy. If you don't talk, there's no therapy. So he'd get them laughing, but it's true. It's talk therapy, and AA is 12-step meetings are talk therapy. You got to talk to get the therapy. So there's many, of course, therapeutic dimensions to catharsis, to imparting an exchange of knowledge and information, clarifying as you talk in your own mind, having that witness testimony, as it were, from people listening to what you have to say is therapeutic. There's all different dimensions to that.
And then think about the power of consistently doing anything. Let's just say once a week for 10 years.
Yep.
I mean, like you said with the gym analogy, if I work out on the elliptical once a week for an hour for 5-10 years, what impact is that going to have on my physical health? No matter what I think about it. No matter what I think about it, John. But I did it every week for an hour or 3 times a week and as a function of these data versus not doing any of that at all. Of course, there's going to be a positive impact that manifests in this case in relapse risk. Super, super interesting. So I want to ask you, I think we got a lot out today too about, and we might actually post some of the slides as we're talking about it, so people can see the visualizations of what we're referring to as we're referring to them. But the ingredients of recovery was, I think, really powerful. There are what we might say in terms of our nomenclature in the recovery community is there's seasons to recovery, and I think that we were able to observe some seasonality changes and recovery maturity across cisgender, sex, and across, what was it, age? Was it age? Can you speak to that a little bit? I know we don't have those pie chart, and
addiction severity.
Yeah. It
Yeah, it was interesting. Yeah, because we've learned a lot in the mechanisms of behavior change research. In other words, how does AA, groups like AA, confer this relapse prevention benefit over time? How come when we link patients from treatment to AA, they do better? Why do they do better? Well, they do better because they go into meetings. But what happens at meetings or as part of the program of 12-step program and the fellowship? How does that transfer into benefit? And is it the same for everybody, or do people differ in different ways? Do they benefit in different ways, depending on who you are?
That was fascinating, yes.
Yeah, so this is really an interesting area, what we call, mediation or multiple mediation or moderated multiple mediation, where you're looking at, the multiple ways that AA confers benefit, and then does it confer it equally for everybody, or do people differ in the degree to which they benefit in those ways? And so we found some really interesting things there. And don't forget as well, you mentioned the word seasons. There is a temporal dynamic aspect to recovery, of course, is early on there are certain needs that people have in general at that stage of their recovery, but you've also got other intersecting factors such as how old they are, because how old they are is a marker for life context. So if you're in your teens or 20s or 30s, you may have different tasks, developmental roles and tasks associated with your life, right? And also, if you're a man or a woman, as you're alluding to, women have different demands and roles than do men on average, and at different stages of their life. Then you mix that in with different stages of recovery. So there's all these dynamic aspects and contextual factors that you have to think about. And we don't always think about it when we're delivering treatment, of course. We think everybody's the same.
Right.
And everybody has the same clinical course or the same needs at that phase of recovery. But it may differ if you're 20 years old getting into recovery, if you're 40 years old. It may differ if you're a man or a woman, a young man or a young woman, etc. Right? So there's intersecting factors, in other words, and that's what we've started to uncover and discover in terms of the types of mechanisms through which groups like AA confer benefit. It differs. What we find is it differs for different people at different times, and it depends on sex, their sex, and as well as their age, so their life context, as well as severity of addiction. For example, we found that men and women benefit to the same degree from participation in AA, but the way they benefit differs quite dramatically. The biggest risk factor for women was low confidence in their ability to stay sober when they're experiencing depression or anxiety, negative affect, broadly speaking. So when women were depressed or anxious and they didn't have confidence in their ability to cope with that, they had a very high relapse risk. That was the biggest predictor of relapse among women. For men, that was not even present. That was not a predictor of relapse for men.
So fascinating, yep.
For men, the biggest predictor of relapse for men was their ability to cope with high-risk social situations where alcohol was present. So this could be a party or a sports event or something like that.
And again, this is on average, but it's still fascinating.
On average, yeah. But the magnitude of these differences was so striking, as you saw.
Right.
And maybe we can put the slide out when in the course of this podcast. But the magnitude of that difference, to me, hit me right there. When I saw it, I thought, wow, look at the for women, this is such a stark difference, for women and men, such a big difference. But what was interesting, of course, because we're talking about the mechanisms of behavior change through which AA works, is that they were using AA to help them deal with it. In other words, they benefited the same, but they used AA in very different ways. For women, they were able to prevent relapse by AA's ability to help them cope with that negative affect without drinking. For men, they used AA to help them cope with the high-risk social situations without drinking. So they're utilizing ostensibly the same intervention here, Alcoholics Anonymous, in different ways to benefit them to prevent relapse based on their needs and their life context at that particular phase of their recovery.
Yeah.
I think that's what's really interesting.
It's very interesting. And in hindsight, you would say, well, that makes sense.
Yep.
But few of us would hypothesize that there would be those differences. And it's almost like maybe for men, reconciling the work that needs to happen related to identity. You know, who am I going to be? How am I going to interact within my? Who am I going to hang out with? Are we going to watch? Are we going to be able to go to Fenway Park, as we talked about earlier, and have a good time without drinking? You know, and that pressure of what that means for what my life might look like if I participate in this program, you know, versus an ability to cope with, might I say, life on life's terms. Not to say that those other things aren't at some point also moderators for certain individuals, but on average, I think that visualization is super powerful and could change too, John, maybe how we present these resources to different populations in the treatment context, and in terms of what the group topics are, in terms of how we support people in those early days, you know, and we also saw differences, or I didn't run any of the analyses, but we also observed differences in age. Is that right?
Yep.
Was it 30 and under and 30 over?
Yep. Yeah. 18 to 29-year-olds and 30 plus.
Right.
So, yeah. So
which on the face seems, okay, that makes more sense when you're younger. I have different needs. I have different life context. Maybe topics outside of group are going to be a little bit different. So can you speak to those? What were those off the top of your head?
Yeah. So again, very similar kind of storyline in the sense that the younger people, the 18 to 29-year-olds, the young adults, they benefited to the same degree as their older adult counterparts who were 30 years and older. They derived as much relapse prevention benefit from AA participation, but the way that they benefited differed dramatically. So for young people, what was really helping them to maintain this level of remission and recovery was AA's ability to help them drop the high-risk people out of their network. That was also true for the older adults, but less so. And in the older adults, it also helped not just drop the heavy drinking drug users out of the network, but it also helped to adopt abstaining and recovering individuals into their network. That was not true of the young adults, probably because there are fewer young adult people in those meetings that they were recruiting to be engaged with part of their network. In other words, it's maybe harder for the younger people to find other younger people who they recruit and adopt into their social network as part of their social network. Excuse me. But what was also interesting was that we only explained a half of the same amount of the effect as we did for the older adults. So we explained 50% of the effect of AA on relapse prevention in adults. In the young adults, we only explained 25%. So even though they benefited the same, we could only explain half of the amount of the way that they benefited. So we got our work to do in terms of understanding more about both groups, of course, because we're only explaining 50% of the effect of AA in the adult group, regular adult. But in the young adult group, only 25% of that effect of AA on outcome was explained through these mediators, these explanatory variables. So, you know, some other clues are things like impulsivity, for example, as I mentioned. But
yeah, that's really interesting. Do you know how those data were measured? I'm curious as to how the negative affect or, you know, changing relationships. I mean, I assume that was a survey of some kind that was implemented in the sample. Yeah.
So self-reported.
Yeah.
Based on the nature of how many relationships, you know, what the status of each of those people in their close social network was. Yep. Were they drinking, drug using, you know, how much they valued those people. Yeah. So, and then they look at that change over time. Yeah. I just think that's really interesting, especially and I appreciate you calling it out too in the presentation that, hey, look, although this is significant and it's interesting, it only explains 50% of the variability between AA participation in this case and relapse risk, correct? Yep. You know, and so how we might identify what those things might be, whether it's impulsivity or oh man, that seems like a bottomless pit of different ideas that you could throw in there, but I'll be curious to see if we can replicate that in some ways and close that gap. You know, explain 75%, explain 90%. Was it common in research of that? One of the things we were talking about at lunch is machine learning. Not to go down a nerdy black hole with you today, but you know, the model
probably don't even remember exactly the type of model. Well, the mediating moderators, path model essentially,
Yep.
which is limited to our own thinking about what might be significant. I mean, the researchers as a part of the study hypothesized, okay, wait, we think it's going to be these dynamics, and we're going to test that. And it just so happened that you got an incredible effect, 50% and 25%. Do you see in the future that technology might help us close that effect size gap? Or do you think that it'll still be kind of our relationship to what we can envision the relationships might be? Are you following me in that?
Yeah, no, I think, I think there's always going to be advancements with technological aid and computer processing power. We've witnessed that over the last several decades now. Just the magnitude improvements in terms of our processing capabilities, which has enabled us to do, more precision type medicine, where we can identify particular, phenotypes or expressions of the illness. Because all of our categories of illness, there's a lot of variability in the expression, presentation of those symptoms. That not everybody's the same. In other words, there's variability in how that disorder, that disease may be affecting them. And a classic example is addiction, substance use disorder. It tends to have a highly variable presentation that's influenced by many other things. Not everybody is the same. And so if we can get closer to identifying, particular approaches, their particular needs and particular things that will affect particular people, specific people, ideally, we're onto a winner. And this is, of course, the dream of precision medicine. You identify particular expressions that we have a particular treatment that's a good fit for, like a key that's fitting in the lock.
Ideally before the maturity of the disease state.
Yeah, before things get much worse.
Bad.
Yeah, exactly.
Yeah.
Right. So, I think there's two things. One is measurement, getting the right measures of the right things, knowing what to measure. And of course, that comes from our theory about how people are affected and what the deficits are and the things that we need to target in treatment in addiction. So there's theory and there's measurement, and then there's the how do we analyze it, right? How do we analyze and with kind of what they call now big data, which you had a little bit of lunchtime. The data you're collecting here at Cumberland Heights, all those data points that patients are filling out, measures, and you're collecting to be able to help patients better by identifying patients who are maybe not responding as well as you would like, to be able to identify those so you can help them better. So utilizing those kind of big data sets to be able to supplement, augment.
With an acceptable range of reliability and validity, to answer very similar questions.
Yeah, exactly. How can we improve care? Yeah.
Yeah, and it's going to be interesting, especially, I've seen such a significant change even in 24 months when we talk about big data or algorithms, or I even hate to say the buzzword, so I'm not going to, but and how we can answer questions. So hopefully we'll be able to pool, because like you said, it's hard to have the partnerships in a lot of ways. This is why forces work is so important at the national level, is sort of having a centralized clearinghouse that at least at some level is starting and saying, hey, listen, these 10 things are really important. Let's try to do our best collecting that, and then naturally this will evolve. And it'll be interesting to see, too, how it changes as a function of the data input. We talked about that a little bit. You mentioned it, whether that's a digital phenotype, for psychology, or the presence of a diagnosable trait that you can model in smartphone data or wearable data. Do you know of any work that's emerging related to that? I mean, are we on it as in terms of our research groups throughout the country focusing on those?
Yeah, in terms of biomarkers as well as kind of EMA type.
Yep.
So both, yeah. So kind of real time, in other words, moment to moment assessment, both passive.
Not essentially, for anybody listening, not a survey. Data inputs that are not classically. So when you think about research, you're not filling out a Likert scale.
Yep. Yeah. So there are lots of instances now, and there has been all along in terms of ideally being able to identify, biomarkers brain imaging, all kinds of things, neuroendocrine factors, any kind of biomarker has been looked at a lot. Now with the wearable devices where you've got passive monitoring of heart rate variability, pulse and all those kinds of things, temperature, you can maybe, the idea is that there's autonomic factors, autonomic arousal factors that can be monitored. And to the extent that they give kind of clues or cues or early warning signs to relapse, they may be able to be utilized in two ways. One is to understand the mechanics and precipitants of relapse and recovery, as well as early warning signs that could alert the person before it's reached conscious awareness. So there may be things going on under the hood that's outside of conscious awareness, that coming to conscious awareness that they're not aware of. These autonomic arousal factors in the sympathetic nervous system, for example, like stress and other factors. So if we can identify those through these passive monitoring devices, like Fitbit type devices, then we can understand more of those. It's hard because it's just so complex and dynamic. This is the challenge, because our central nervous systems are going up and down all the time. Doesn't mean even though it's hard to predict relapse because there's cognitive intervention. So I might get craving, but then if I'm motivated and if I do, I can intervene. I can say, you know what, I'm feeling that. I don't want to go there. I need to implement my 911 plan, my emergency procedure, my relapse prevention. I need to call my sponsor. I need to get to a meeting. I need to get out of this venue, this situation right now. So there's emergency maneuver. So it's not just a matter of understanding the biomarker risk, because there's lots of ways that people avoid that. So it's not predictive. In some cases it predicts, some cases it's not. So this is where it becomes complex, and you think, well, you're scratching your head saying, wait a minute, I thought that predicted relapse, but it doesn't, because some people who are more motivated will cognitively intervene to prevent that from happening. So it's, this, again, the biopsychosocial and dynamic aspects, which makes, predicting human behavior very difficult.
Yep. And that's the dream of measurement-based care, which is very celebrated in the private treatment world with surveys, psychometrics, which is very powerful, very valid, very reliable. But it'll be it's going to be an interesting next decade to see how we might be able to just reduce risk. Really, like you said, because it might be that even for somebody who has established recovery, that the algorithm is telling them, hey, you're at risk for relapse. And what do you do with that information? Almost like your recovery score now, these popular B2C applications like Whoop, and your rest rate and your recovery score, and people not knowing what to do. Am I really rested? Am I not rested? Yep. And kind of how those algorithms mature over time are going to be really interesting. Yeah. I do want to change the subject because I think that there's a lot of folks that are interested in other manifestations of addiction. We talked a lot this morning about alcoholism, about classic addiction, i.e. methamphetamine or stimulants or what have you, and an ability to, stop using in spite of tremendous negative consequences. But what we're seeing from a provider perspective too is the impact of other addictive behaviors like gambling, gaming, and pornography. And I wondered if you had any comments about that, because we know, neurologically that the same pathways are activated as associated with those behaviors and activities. And sometimes I wonder if we should be doing more work. When I say we, I mean the provider network. Should we be doing more work in terms of how we identify frequency and intensity of use along those domains, and how that might impact somebody's recovery trajectory outside of abstinence from using or drinking.
Yeah. Well, you're raising important points, and we're seeing these increases in all of these things with free online pornography, endless access to gambling now with the sports apps, betting apps, and then, of course, digital access to digital stuff, period, as well as gaming. Video gaming, which is very habit forming, if not addicting. And again, depends on how you use that word addiction, because it's been overused. Of course, it can be overused to apply to all kinds of things. But I think it's a good fit. The addiction paradigm is a good fit certainly for gambling, probably for several other things as well. But gambling, I think, is a well-articulated, well-defined, kind of fits more of the classic paradigm of addiction that we see with psychoactive substance use disorders, alcohol, amphetamine, opioids, etc.
As opposed to sex or food addiction.
Yeah,
I understand.
Now, it could be now that for certain people, it's just not as prevalent. Now, I think there's more work to be done with sex and food. They operate through the same pathway, as you mentioned, a very similar reward pathway, plus or minus different degrees of chemical cascade.
But you need those two things to survive, as opposed to heroin is not a necessary portion of our diet.
Yeah, so, it's certainly, they're very important in their own right, but they're also important as comorbid factors in the presentation and treatment of psychoactive substance use disorder, because some people may have comorbid alcohol, marijuana, or other psychoactive substance use disorders, of course, but also other behavioral, so-called behavioral addictions, like sex, like gambling, like food, exercise, gaming. The other problems, maybe they haven't risen to the same level as their presenting problem, whether that be amphetamine or alcohol or whatever. Or it might be, maybe they're presenting with a gambling addiction, but they have comorbid alcohol use disorder, which is, a kind of a co-facilitator of their gambling. They start to drink, and then that disinhibits, that then sets them off.
Hand in hand.
Hand in hand, exactly right. And they're off to the races, literally.
I have a friend who runs a program in Colorado, and it's a program for young adults, and it's a transitionary program. So it's a classic treatment in terms of, it's a phase system where over the phases you graduate to higher levels of, for lack of a better term, privileges in terms of what you can do and your living quarters and all this. One of the things that you earn back is your phone. And we've been having these interesting conversations. He's a clinician. I tell him he's a researcher all the time. He's anecdotally collecting this information in his health system, and what he's doing, which I haven't told you about, but what he's been doing is monitoring screen time reports. That we all get, which is very depressing once a week when I receive it.
Right.
What was your average daily number of hours and minutes that you're on your phone, and he's just been writing this down, in Excel. And what he's been observing anecdotally is that higher screen time within this population is associated with increased risk for relapse and leaving the program altogether. And so he's been starting to implement just group, like he's just trying to figure it out. He's not trying to publish a paper. He's trying to help the individuals that are in his programs. But it just has me thinking about, maybe we should be talking about this more. These things these appendages, that we walk around with every day, and what kind of power they might have, what kind of stimulus they might introduce unknowingly that we otherwise didn't have a problem with 15 years ago. 2007, whatever that math is, before somebody was leaving treatment. So it's really interesting. I'm grateful to you, Dr. Kelly. I think the word, I don't want to make you uncomfortable, but you are a bridge. I think that, if I may say so, what your work has really meant to the field at large and to our recovery communities is really a bridge. I think there was a documentary a couple years ago, The Anonymous People, Greg
Williams.
Yeah. And I think one of the lines in that documentary, I'll give him credit anyways, and everybody that put that together, was that part of the problem with our programs in terms of data and in research is largely that we're speaking in a language that other stakeholders can't hear in, that other science is speaking, which is peer review. And one of the things that I really, because it's not easy to write over 200 peer-reviewed papers and to fly down to Nashville for 2 days and and present on your findings. But I do think that your work is having a tremendous impact on our ability to communicate what's really happening, and how it helps people change so that we can help more people. Because I've heard that addiction's not going away, So I just want to thank you for the 2 decades plus of work. Before I let you go, what would you tell families, just pragmatically, what would you tell families to look for in a treatment provider? What's important that they might see in order to make what you believe would be an informed treatment decision? I won't hold you to it, too. We can cut it out. What do you think?
Well, let me first say I've been called a lot of things in my life, but I have never been called a bridge. But I think that's a compliment.
Yes, it is.
Unlike the many other things
Right.
I've been called. But thank you for saying that. I think, if you're asking, what do families look for in a good treatment agency or a good treatment provider, I think actually we have a list on Recovery Answers. I think you may mention this earlier, but the Recovery Research Institute website is recoveryanswers.org. And on there is a lot of information on the website about addiction, treatment, and prevention and recovery. But there's 11 things to look out for. It's on there where people can actually go and kind of get the right questions to ask if they're vetting a treatment provider. But one of the hallmarks, I think, is are they accredited by some external agency like CARF or JACO, so one of these external credentialing bodies. That's a good kind of a hallmark because it's a testament to their willingness to be open, to be transparent about their practices. I'd be very skeptical if a program didn't have something like that. So that's one hallmark you can look for right off the bat. Are they CARF or JACO accredited? Because that's a quality indicator right there. That covers a lot of bases. I think having credentialed, licensed staff, evidence-based treatments, all of these things, do they do outcomes measurement? Do they incorporate measurement-based practice into their paradigm so that they can improve the quality of care? Again, a hallmark. To me, that would be a hallmark of a good quality program. They're actually actively trying to improve care by measuring the response of the patients that they treat, like you do here at Cumberland Heights, which is admirable. And I think programs that have adopted that and adapted that to their own context are, again, another hallmark of good quality treatment, or a program that's really trying to help patients in the true sense.
Yeah, thank you so much.
Not trying to just cash in. I'm skeptical. On the other hand, I'm very skeptical of any program that says, we have an 87.6% cure rate or success rate, whatever that is. What is success? Does that mean, patients that they treat are in remission for 5 years after treatment? They never qualify exactly in what they mean by success, but those things are kind of very misleading and exploitative. Yeah. I think those kinds of very misleading statistics at a time when people are very vulnerable and they're desperate looking for help. So that's not helpful.
Yeah.
No, I'm very suspect of any sites that had those specific statistics on quote unquote success rates.
Yeah. Well, thanks again. We really appreciate you spending time down here. I'm really glad that I was able to serve you your first Meet and 3, shout out, here in Nashville, Tennessee. If you're interested in learning more about Dr. Kelly and his work, we're going to pin the website associated with the Recovery Research Institute, recoveryanswers.org, in the description. Please like, follow, share, and subscribe. We appreciate you guys listening. Until next time, see ya.